couple of different areas. One of them is where we stand in terms of evaluation of patients, what we really do in terms of looking at a patient, sorting out what his problems are, and then how to help fix them in terms of what treatments can be provided. It's really a pleasure for me to be here and to speak at a time. I think Rabbi Flom has already given us information in terms of how we should approach the evaluation of patients, how we should be understanding essentially the natural laws better so that we can translate that into treatments. And in the last 3 or 4 slides, I'm going to talk a little more about the future and where we're going. In some ways, I think it is disappointing that we are providing similar treatments to what we've been doing over the last 10 to 15 years. On the other hand, as Dr. Davis has pointed out, there's a number of areas where we've tremendously improved the efficiency of our treatments, and as Dr. Goldschlag briefly mentioned, really understanding the genetics and doing studies in that area, I think are going to allow us to understand and to help more and more couples as time goes on. Okay. So I'm going to talk about some of the basics in terms of how we evaluate treatment options. The fact that treatment is always coordinated. When we're doing something on the male side, we're doing this in coordination with the entire IVF team that Dr. Davis and Dr. Goldschlag work with. And when I say we, I'm referring to the entire group of our male reproductive team, Dr. Darius Paduch, Dr. Mark Goldstein, and myself. And some of the more detailed information in terms of treatments we provide and how we do it is in the back with Mark and Hyacinth from Dr. Goldstein's office. And Dr. Goldstein and Dr. Paduch will be here later this afternoon to talk about what they have for treatment as well. We certainly now are able to treat some of the more difficult cases, some patients we thought were untreatable in the past. And I'm also going to talk a little bit about cases where IVF has failed and where we now understand that there are sperm problems that have contributed to it, again, in addition to the future. When we evaluate a male, very often we start off with looking at a semen analysis, at the fluids that are actually produced and analyzing that. But we're also concerned about whether sperm, whether semen are actually interacting with a woman. So often a postcoital test may be the first test, even though that's not a very exact scientific test, a test done after a couple has relations. We then look at the background of the man, and usually we'll use a questionnaire because there's so many questions, there's so many issues that can be involved. You can't go back and forth and ask every question about every individual factor that may affect a man, and I'm going to talk a little bit about testing as well. What we're really focusing on when we look at a man is we're looking at those conditions that we can treat in some way, whether they are mechanical problems often related to sexual intercourse, or whether they're hormonal abnormalities, whether there may be blockages that are preventing sperm from coming out or affecting sperm and their quality as they come out, and those, of course, can be treated in a variety of different ways. Whether there are toxic factors, whether there's something that's actually affecting the man and his sperm production, and even some of the medications that are routinely used can affect sperm quality and or how sperm come out of the body and can result in decreased chance of success of any of our treatments. Varicoceles or enlarged veins around the testicle are commonly present and can affect sperm production, although not all veins need to be fixed, and fixing veins for an individual man doesn't always allow that couple to achieve a pregnancy. And certainly one of the areas where we thought that men were untreatable, men where the testicles work so poorly that no sperm come out of the body, or what we call testicular failure, is very commonly treated at our center. The history that is obtained is whether a couple has had children before and how long they've been attempting to conceive, as Dr. Davis talked about. As time goes on and a pregnancy has not occurred, the chance of that pregnancy occurring on its own becomes smaller and smaller, and therefore treatment is more and more worthwhile. We want to know that the woman is being evaluated at the same time. We want to know a lot of details of men's past history. If they've had treatments like chemotherapy or radiation or other interventions in the past, that's critically important to us. We want to detect any infections and know if infections were previously present in a man, and certainly a surgical history, whether a man has had surgery, particularly in the groin area, is particularly important. We're also interested in how he developed, because some of the development that normally occurs during puberty tells us about what may be going on with hormone influences. And again, medications as well as heat exposure, other factors that can affect the testicle are important. Occupational exposures, fortunately, are pretty limited. It's relatively rare that a man in the workplace will actually be affected by toxins that affect sperm production. But we do want to know about that. We want to know about how a couple is having relations, how they're attempting to conceive, and although we ask about a family history, it's relatively unusual that infertility runs in a family, because if fertility problems were severe enough for the man, usually in the past they did not have children, at least children at the age that we see now. When we're looking at these things and when we're examining men, we're thinking about all of the internal structures that lead to the testicle and lead to normal function. So we don't just think about what may be present in the scrotum or the sac. We think about more than that, and we examine more areas of the body, and that is what's in the back of our mind as we examine a patient, look at them, and consider what is affecting them. We also look very carefully at the sperm, and the sperm analysis or semen analysis really looks at three major factors. One is concentration, the number of sperm that are present. Two is motility, the proportion of sperm that are swimming. And third is morphology, or the shape of the sperm. We call concentration, or most lab tests report concentration as being normal when it's over 15 or 20 million. But a normal man actually has 60 or 80 million sperm. If you get below that 15 or 20 million number, that alone can be enough to affect the chance of pregnancy occurring. And again, that's when we start to look at what can be done for treatment. Genetic evaluation is worth doing if the sperm numbers are even lower than that, because that may give us clues in terms of what is the cause of low sperm production. If motility is particularly poor, there is no non-specific way to improve that motility, but again, it can be a clue to us that there are antibodies that may be affecting sperm, that could be partial blockages, that sperm are being hung up or delayed in their transport through the body, or that there could be some other abnormality or damage within the sperm that we should investigate or know about. As Dr. Davis talked about, if you even have one motile sperm, in theory, you could use that with assisted reproduction to allow pregnancies to occur. Low motility is of concern to us because if you're trying to use those sperm, wash them, for example, in IUI or inseminations, then the low motility reflects the fact that sperm are probably not going to survive very long and is a concern for the results of that sort of treatment. Low motility can also be caused by infections, and so that triggers us to think about the potential possibility of infections. The shape of the sperm is critical for IVF success. Only normally shaped sperm will actually fertilize an egg on its own. Fortunately, ICSI will take even sperm that appear abnormally shaped and allow them to fertilize. Fortunately, abnormally shaped sperm don't have an increased risk of having genetic abnormalities, meaning even though we may be using some abnormal appearing sperm, that doesn't increase the risk of genetic abnormalities in the children that you're having or the risk of birth defects. It's very common for people to be concerned that if you have abnormal appearing sperm, you're going to have abnormal children, but that's not the way it works because the morphology or shape doesn't correlate very well with the internal genetic quality of the sperm in most cases. The semen analysis numbers we use, and we sort of quantitate all of this together to try and figure out what the likelihood of a pregnancy occurring. In this yellow curve here, basically you see month by month, 2 months, 4 months, 6 months, 8 months, if the sperm numbers are normal, what proportion of couples will achieve a pregnancy. If the sperm numbers are abnormal in different ways, then the chance of pregnancy is clearly lower. And one of the reasons we start evaluation after a year or so of infertility, a year or so of attempts without achieving a pregnancy, is that these curves become very flat after that year or so. So when we're trying to do a treatment, for example, when you're considering varicocele repair, what we're trying to do for couples is to shift them from, say, this green curve up to the orange or red curve, or from the orange or red curve closer up to the yellow curve. So that's how we look at what a semen analysis, what these sperm numbers mean, and what we can do to try and change that. In men who have low sperm counts, we'll typically have hormone blood tests that are done as well. At baseline, those are usually FSH hormone tests, like Dr. Davis talked about, that reflects how the testicle as a whole works. Also testosterone levels, because that tells us whether there's potential treatments that could be provided. Sometimes that's with clomiphene, sometimes that's with anastrozole or arimidex. There are a variety of ways to help trick a man's body to